So the topic that we are going to talk today is mechanical ventilation and its strategies in acute respiratory distress syndrome. Okay, so the topics that I would cover is, I think you need to understand what ARDS means, and the whole concept of ventilation in ARDS is based on three pillars. So the most important pillar is this low tidal volume. Okay, so that is something I think all of you here who are playing with ventilators should understand. And when you talk about low tidal volume, you need to understand what is the benefit and what are the harms and how do we apply this low tidal volume. Then the second one we need to understand is the offbeat of low tidal volume is you can have permissive hypercapnia. So this hypercapnia, although sounds dangerous, it can be beneficial, and how much we can allow is something that we all need to comprehend. So the first pillar is low tidal volume. The second pillar is high PEEP, the PEEP or high PEEP. So PEEP is positive end expiratory pressure, and even so these are the two important elements which we need to tweak to optimize ventilation in ARDS. So for the PEEP, you need to understand the benefit, harm, and how do we apply PEEP. And the third important thing is recruitment. So recruitment is when your strategy of low tidal volume or high PEEP is not achieving your desired oxygen saturation in a patient, then we have to consider something called recruitment. So in between low tidal volume, high PEEP and recruitment, now the new concept has come called the driving pressure, which is a combination of tidal volume and plateau pressure. So I think we need to deliberate upon it as we go along. And briefly about invasive versus non-invasive ventilation and refractory hypoxemia, where you have done low tidal volume, you have done your PEEP optimization, you have done recruitment, but still patient is refractory, then what are the other tools that we have to optimize the oxygen levels? Bit on titrating the PEEP, because when we say high PEEP, I think we all need to understand what is the meaning of high PEEP and what is the number that we put for that, and summary and recommendation. So I think the acute respiratory distress syndrome, why is it important? Because it is a common condition which can lead to poor clinical outcomes, because patients can die because of ARDS. The mortality can be anywhere between 40 to 60%. And when it is combined with a erroneous ventilatory strategies, it can lead to ventilator associated lung injury. VALI means ventilator associated lung injury. So ARDS per se can be very bad for the patient, and ARDS per se can kill the patient. But along with it, if your ventilatory strategies are bad, which means you don't adopt the concept of low tidal volume and optimal PEEP, then that will accentuate or worsen the mortality. So you need to understand that ventilatory strategies become extremely important, because your whole ventilatory strategies is to reduce the occurrence of iatrogenic VALI. VALI is ventilatory associate, because if you do not use proper science in ventilating a patient with ARDS, your whole ventilation itself can cause harm, which is ventilatory associated lung injury. So the whole effort we are going to deliberate is to reduce this ventilatory associated lung injury, and what is the science behind it. That's what we are here to understand. And what is this strategies? As I'll be repeating this. It's a low tidal volume, PEEP, and open lung ventilation is a combination of low tidal volume and PEEP, recruitment and PEEP. So these are the only four elements that you need to really keep in mind along with driving pressure, to make sure that the harm created by your ventilation is reduced or mitigated. So what is the definition of ARDS? So anyone who comes with shortness of breath, who has bilateral opacities, so you have a fluffy opacities on both sides, and you have ruled out the cardiac cause, and these opacities has risen after within 1 week of patient getting fever or cough or sore throat, and whose PaO2 by FiO2 is low, because if you have your PaO2 FiO2 less than 300 with a PEEP of 5, we call it as a mild ARDS. If it is less than 200, PaO2 is the oxygen that you get on a blood gas, FiO2 is the amount of oxygen that you are delivering to the patient. Less than 200 with PEEP of equal to or more than 5 is moderate ARDS. Severe is where your PaO2 by FiO2 is less than 100 with PEEP of more than 5. So you categorize ARDS as mild, moderate and severe. So mild is less than 300, you have to remember that number. Moderate is less than 200 with a PEEP of 5 or more, and severe is less than 100 with PEEP of more than 5. So this is the Berlin definition, because before we had a different definition. This got revised few years back, and now this is the definition we accept. So any patient you see in your hospital or in your practice with bilateral opacities where cardiac cause is ruled out within a week of having an inciting event and having low oxygen of that ratio, despite giving 5 PEEP, you call it as ARDS. Okay. So why is it important? Why is ARDS important? As I said, the mortality is very high. Because if you look at the mortality statistics, in the mild ARDS, the mortality is around 27%. If you have a moderate ARDS, it's around 32%. Severe ARDS is 45%. So most patients we see in our Columbia Asia hospital, because considering it's a referral hospital, we get severe ARDS and they would have been treated outside and even they may have been ventilated, and when they come to us they either fall in the moderate ARDS or severe ARDS, so which is where the mortality reaches around 40 to 50% upfront. So which means there every two patients you treat there is a risk that one can die if you do not ventilate them properly. So that's why the science of understanding what do we understand by proper ventilation is what we are here to understand. Okay, so we'll go slowly through low tidal volume ventilation. So low tidal volume is, in ventilator we fix the tidal volume. Okay, the volume of gas that you are going to deliver is the tidal volume. So low tidal volume, the reason why we adopt this low tidal, because if you have an ARDS, this is how your lung looks. Some of the alveoli, this alveoli is collapsed, and this has lot of infiltrates and it is flooded. So this is non-functional alveoli. So this alveoli is sort of open, and this alveoli is sort of over distended. Because the reason why this happens is, says you are delivering 500 ml of oxygen into the patient. So which means that 500 ml is non-equally distributed in the lung because of the pathology. Because you have a pathology here, there is no equal delivery. So there is a very heterogeneous delivery of oxygen, and what that leads to is over distension of normal alveoli. And this over distension has to be prevented. We call it as a volutrauma, because you are giving more volume of gas into the patient. So the normal alveoli can get distended and abnormal alveoli do not open up, and this we call as volutrauma. And the low tidal volume is, the concept of low tidal volume is developed to reduce this over distension or to reduce the volutrauma. So that is what we mean by giving low tidal volume, so that you want to mitigate the effect of volutrauma. And what is the benefit? Why do we give low tidal volume? Because we have to reflect on whether this sort of a science at the alveolar level extrapolates to the clinical outcome. So that's why we have to look at the studies. So the benefit it has shown, by doing this alone, it improves the survival of the patients and reduces the mortality. And the first trial, the landmark trial, came from USA. It was called ARMA trial. It came in 2000. As you see, this was the group which got low tidal volume. Low tidal volume is, your intent is to prevent over distension of the alveoli, and you saw that it had a direct bearing with survival. So in the low tidal volume, the deaths was 31% in low tidal volume. In normal conventional tidal volume, which is 10 to 12 ml per kg we give, that was 39.8, and that was statistically significant. And even the weaning was found to be much better. So breathing without assistance at 28 day was much better in low tidal volume group. And number of ventilator free days, which means the duration of ventilation was lesser. Ventilator free days, if it is more, it is good. So that was better in low tidal volume as compared to the conventional tidal volume. And number of days without failure of non-pulmonary organs also was better. So if you see all the derivatives, it was found that patients did very well when they used low tidal volume. So this whole concept came from this landmark trial called ARMA trial, which came in 2000. After that, obviously one study shows a dramatic effort, so there are multiple people who would do studies. So the German people did a big meta-analysis of 1149 patients, and even there they found that your risk of dying is significantly less with low tidal volume. As you see, it's 34.2% when compared to conventional ventilation with 41%. So, and that was also static. We can see confidence interval is 0.58 to 0.96, which is statistically significant. So even if you put bigger number of patients and did a systematic review, they found this benefit persisted. That's why we emphasize a lot, because anyone who is playing with ventilators, I think this concept of low tidal volume has to be extremely clear in your mind. And after this German study, in 2013, the Italian study came with a much larger number of patients. Even there they showed that 28-day mortality was significantly less in low tidal volume group as compared to the conventional mechanical ventilation. And even your hospital deaths mortality was significantly less in low tidal volume group. So why it is important? Because whenever we hypothesize something saying that low tidal volume will reduce the over distension, it has to extrapolate into your clinical science or your clinical outcomes. And this is what these three studies have shown, that by adopting low tidal volume, that you can really save lives in a patient as compared to conventional. When we say low tidal volumes, it is anything less than 8 ml per kg of tidal volumes we deliver to the patient. If it is a conventional, it will somewhere between 10 to 12, which earlier people were using for any ventilated patient. And this was another study from USA where they found by adhering how much reduction in mortality that can happen. So this was a prospective cohort study they did in 485 patients, and they saw that if you have 100% adherence, suppose if you are treating all your patients with ARDS with low tidal volume, there was 7.8% reduction in deaths. And if you adopt for 50%, I think there can be reduction of death to 4. So the more you adhere to low tidal volume, the better is your ability to reduce the deaths in patients with ARDS. So this is what we understood. So can there be harm by giving low tidal volume? It has been found that clinically adverse outcomes were not much. So which means it is safe to give low tidal volume, provided you understand the science and you are able to monitor certain things, which we will talk about well. But because you give less volume, so less delivery of oxygen, so it can lead to increase in carbon dioxide. Because you are giving less oxygen, then carbon dioxide builds up. So there is something called respiratory acidosis that occurs because carbon dioxide tends to retain because you are giving less oxygen. And by giving low tidal, because basically you are giving less volume to the patient, less amount of total delivery of gases. So what it means is patient tends to gasp for breath. So there can be increase in the work of breathing, and there can be dysynchrony. Dysynchrony is how well you are adapting to a ventilator that can be disturbed by giving less tidal volume. So these are some of the disturbances that we see in patients where we give low tidal volume, but this all can be circumvented by certain strategies. So what are those strategies? By increasing the sedation, because obviously when there is work of breathing, when patient is struggling to breathe because you are giving less gas into him, then you have to settle him down by sedating him. And when carbon dioxide goes up, do you think it is going to be harmful or beneficial? In ARDS, because your carbon dioxide goes up, it produces something called auto PEEP. Because as I kept telling, the three tenets of ARDS is low tidal volume, high PEEP, and recruitment measures, driving pressure. So these are the four elements which we need to have very clear in mind. And open lung ventilation is combination of low tidal volume and PEEP. So because you need that PEEP, your high carbon dioxide which you attain with low tidal volume has a beneficial effect because it is adding on to the PEEP in a patient. And it has been found that with low tidal volume, the amount of auto PEEP that gets generated is negligible. And they did a study to see whether low tidal volume really means that you have to increase the sedation. This was a study that came from US where they found that when they compared low tidal volume and conventional mechanical ventilation, percentage of days the patient was on sedation, analgesia or neuromuscular blockers was not very different. Which means to say, although you may need to use more sedation, but that may not be very clinically significant, or statistically at least it was not found to be significant in the study that came from USA. I think this slide would be extremely important for people who are playing with ventilators. So we spoke about low tidal volume. How do you apply low tidal volume? So the first step in any ARDS is you have to calculate predicted body weight. For females, that's the formula, 45.5 plus 0.91, and you have to get the height of the patient minus 152.4 centimeters. So that's the formula that you calculate to determine predicted body weight, because the tidal volumes you set is related to the predicted body weight that you calculate. For males, the formula is you just add 50 plus 0.9. It remains the same. Only the difference is 5 difference between this constant 45.5 and 50. Otherwise, the rest remains the same. So the first step that you do in applying is, first, as soon as you have a patient with ARDS who is intubated, the amount of tidal volume you set is 8 ml per kg of predicted body weight. You set that. Then you'll see how the patient is doing. Within 1 to 3 hours, you start reducing it to 7 ml. Because all of you present have to understand, if tidal volume you keep reducing, respiratory rate you have to keep increasing to deliver optimal amount of minute ventilation or the gases patient would need. So you have to increase the respiratory rates as per the need of the patient. And this we cannot define what each patient needs the respiratory rate. This you have to customize based on your carbon dioxide and oxygen levels that you see in your blood gas. And after that you further reduce to 6 ml per kg, and the maximum respiratory rate which is suggested you can go up to is around 35 per minute to circumvent the rise in CO2. Because as you are doing this, when you bring down 8 ml to 7 ml per kg to 6 ml, your carbon dioxide starts building up. As I said, carbon dioxide is good in ARDS because it provides some auto PEEP, but too much rise in carbon dioxide can have a lot of hemodynamic consequences. So to mitigate that, you may have to slowly start increasing the respiratory rate, and you can go up to 35 per minute to circumvent the rise in CO2. And as you are doing this, so you need to know what is the right tidal volume the patient has. So for that, you need to measure something called plateau pressure. So as I said, the science is a little complex for someone who hasn't been doing all this, but this is a bread and butter for our ICU, because for every ARDS patient, our team in our ICU will be constantly monitoring this very important variable called plateau pressure. So P plateau is a very a simple calculation that can be done on a ventilator, where at the end of the inspiration we put a hold for around 10 seconds, and once you put an inspiratory hold, ventilatory will give you this pressure called P plat or plateau pressure. So the whole science of low tidal volume is to reduce this plateau pressure to less than 30, because the science has shown that if plateau pressures are kept above 30, the risk of barotrauma or volute trauma is very high. So our whole science is to reduce tidal volume, increase the rate if needs be to mitigate the rise in CO2, and keep measuring plateau pressure. So this is the whole essence, or this is the whole science of ARDS ventilation. And this gets level 1A recommendation. So if someone is not doing this for ARDS, we are really causing harm to the patient. So plateau pressure has to be kept less than 30 centimeters of water. And to achieve that, you have to constantly keep lowering the tidal volume, even up to 4 ml per kg if needs be. And at the same time, it's not only the tidal volume, you have to start optimizing the PEEP, which we'll talk about. And if PEEP plat is more than 30 centimeters per water, as you see, the tidal volume has to be further reduced to 5 ml or 4 ml per kg body weight. So the target for you is PEEP plat. If PEEP plat is more than 30, it means your whole task that is cut out for you is to start reducing tidal volume up to 4 ml. So from 8 ml, your whole science is to slowly start getting the tidal volume to 4 ml by tweaking the respiratory rate, by increasing the respiratory rate, and by optimizing the PEEP. So what is desirable is PEEP plat less than 30 and less than 28 is what is most preferable. And in ARDS, for all the audience, I think this is also extremely important. We don't target saturation of 100%. We don't even target saturation of 90%. 88 to 90 is good enough for us. So in fact, if you give more oxygen to ARDS, it can be more harmful, because oxygen has a pro-fibrosis activity. So it can cause a lot of fibrosis in the later stage of ARDS. So especially if you have made a diagnosis of ARDS in a patient, our target for oxygenation is 88 to 90 or 92 is good enough for us. We definitely do not want oxygen sitting at 100%. And PaO2, you can anywhere accept PaO2 between 55 and 80. 80 also is high for me. So go with saturation 88 to 90. See, right now in our ICU, we have a ARDS patient where we are maintaining saturation at around 86 because she is a severe ARDS. We have done prone ventilation, and now patient saturates at 86, very comfortable. We are very happy because we want to get her off the ventilator. So you don't have to target very high saturation or get really bothered if your saturations are showing around 88 to 90. That is absolutely good enough for the patient, if as long as patient appears comfortable. And for that, the only things that you will be tweaking is tidal volume, FiO2 and PEEP. I think these are the things that you will be playing around to achieve that end results. So now we spoke about permissive hypercapnia, because in your zeal to lower the tidal volume, increase the rate, still the carbon dioxides will go up. So as I said, the low tidal volume can cause permissive hypercapnic ventilation. So it is called permissive. The reason why we use the word permissive is certain amount of CO2 rise is expected in all ARDS. We accept that because it has some beneficial effects by creating auto PEEP, and the PEEP is advantageous for the patient. And this has shown to attenuate or reduce the occurrence of ventilator associated lung injury, which is a problem if you do conventional mechanical ventilation, because the whole key essence of ARDS is having an absolute good knowledge about how we ventilate the patient. Because your hypoventilation will reduce your alveolar pressure, and that increases your CO2. And this CO2, as we have mentioned, rise in CO2 can be minimized by increasing in the respiratory rate. So otherwise you have to increase tidal volume, or you have to play with inspiratory expiratory time. So these are the three variables you can tweak to reduce your CO2. So I think the first step that you should do is increase the respiratory rate, because we can't increase tidal volumes. Because you increase tidal volume, P plat will go up. Or I'll talk about IE ratio, because you can tweak IE ratio, inspiratory and expiratory ratio, to increase, so sometimes get down your CO2. You have to prolong your expiratory ratio sometimes, but that may be deleterious for your oxygen, because for oxygenation optimization you need to have more inspiratory time. So we'll talk about that later. And other technical thing, if you're playing with ventilators, is reduce the dead space. Another important tool to reduce carbon dioxide is reducing the dead space. So you can shorten certain tubings which you use, because that will increase the dead space. Or if patient has a pleural effusion, so you can think of aspirating pleural effusion to reduce the dead space if you have a huge problem and if pleural effusion is lost. So reducing the dead space also is another modality where your CO2s can be brought down. So these are the only ways that you can get on the CO2. Increase the respiratory rate, increasing the volume we cannot do, maybe prolonging the inspiratory expiratory ratio, prolonging the expiratory phase may help, and reducing the dead space. So these are the only ways we can reduce CO2. But certain amount of CO2 is acceptable. So the question should arise in you, what CO2 can be acceptable? For me, I accept CO2 even up to 60 or 70, provided pH is normal. So our aim is to maintain normal pH and patient's comfort. If patient is comfortable, neurologically okay. So right now I have a patient with ARDS who maintains CO2 around 60 to 65. I'm okay as long as pH is okay. So we'll talk about it later. So we spoke about low tidal volume. We spoke about the permissive hypercapnia. Then we'll talk about open lung ventilation. So open lung ventilation also is an essence of ARDS ventilation. What it simply means is, low tidal volume we spoke about, adding PEEP. It's not only PEEP, optimizing this PEEP is what we call as open lung ventilation. So you saw this picture. So low tidal volume helps in reducing the volutroma, but the addition of PEEP, see, your cause, the low tidal volume we discussed, you want to prevent this over distension and volutroma. But what about this collapsed alveoli? This would not open up with whatever tweaking of tidal volume. This will only open up with PEEP. So PEEP is given to open up the alveoli, and that is one. And second most important thing, PEEP is added because there is a differential opening of these three alveoli. What happens? Alveoli are not static, right? They close, they open. They close, inspiration they open, expiration they close. So when they close and open with these three differential sizes of alveoli, it is called cyclical closing and opening. So what it leads to is, it can cause atelectotrauma, it can cause barotrauma, it can cause volutroma. So you want to make basically all these three alveoli look similar. So to prevent that, PEEP is what is needed. But having said that, you need to put a right PEEP, because if you put more PEEP, it can cause over distension and can cause barotrauma. So there are three traumas in the lung that can happen. Volutrauma because of tidal volume. Then you can have atelectotrauma due to differential closing and opening, cyclical opening and closing. And then you can have barotrauma due to increased PEEP. So these are the three traumas, and our whole science of mitigating this trauma is by optimizing tidal volume, PEEP, with target of plateau pressure, keeping it low, and driving pressure, which we'll talk about. So is PEEP beneficial? So I think the studies which came as early as 1998, so this came from the Brazilian group. Amato is a very landmark article, which he is the one who showed the benefit of PEEP. So here they had 53 patients with ARDS, where they adopted the strategy of open lung ventilation, which is low tidal volume with PEEP, and conventional mechanical ventilation was 24 patients. As you see, the 28-day mortality was significantly less where they gave good PEEP, and hospital mortality also was less, but it was not statistically significant. So that was the first study. And the limitations of this study was, I think they used PEEP only for 3 days and most of these patients were leptospirosis. Okay, so if you do not believe that old study, so this is a little recent study which came from the Spanish group in 2006, 103 patients with ARDS where they did open lung ventilation in 29 and conventional in 24. As you see, ICU mortality is significantly less when you adopt this strategy of low tidal volume with PEEP. And hospital mortality also was significant, or significantly less when they adopted this strategy. And ventilatory free days also was better in open lung ventilation. That was also statistically significant, which means to show, although we believe in the hypothesis, it does translate into clinical outcomes as we see. Okay. So limitations of this study was they used very high tidal volume in the conventional. That was the limitation of the study. So PEEP, like low tidal volume, we thought the deleterious effects of low tidal volume is increase in the CO2, ventilator dysynchrony, increased need of sedation. What about PEEP? Even it is found by giving PEEP, the clinical serious adverse events were nil, and even sometimes high PEEP can even add on to worsening of CO2. So now the second question, as soon it should arise in your mind, is what is the right PEEP, isn't it? Because I said high PEEP. So what do you mean by, I think we should use the word optimal PEEP. What do we mean by optimal PEEP? How do we ascertain? Because every patient is different, every ARDS is different. We can't have one number to this, isn't it? How do we determine how much PEEP to give? For that, you need to see, because anyone who is playing with ventilators, you will see these graphs coming on ventilator. So this is called pressure volume loops, which is pressure plotted against volume. So it looks like this. Okay? So this is the inspiration, this is the expiration. So I think this figure will explain to you what is the amount of PEEP. So if you see here on the x-axis, you will see the pressures. So you have 8, 12 and 14 like that. So even in ventilator, you'll get a graph like this. So this is called lower inflection point. So where the inspiratory curve takes off and where it plateaus is called the upper inflection point. So what that inflection point means is, see your alveoli is like this at the base. So this pressure volume curve is only indicating the inflection point is the time when the alveoli starts opening up. All right. So as you see here, 2 centimeters at the transition point is what is your PEEP, which is possibly optimal in opening up the alveoli. See here it is just opening and 2 centimeters later it opens up fully. And this remains same over certain time and it peaks here, and after that if you continue to increase the number, then it leads to barotrauma. So the whole range between lower inflection point and the upper inflection point, which is here, is the optimal PEEP, and that is indicated by the x-axis. You see the numbers that will tell you. So because if you have a number of say 12 here, then 14 is your ideal PEEP, and then you have to titrate it to the patient. So this is how we tend to apply. So 2 centimeters more than lower inflection point is what your PEEP is, and for this graph it's around 16 centimeter water appears to be what appears in this particular graph. Okay, so that you have to determine on the bedside at the ventilator to see what is the optimal PEEP for these patients. And the second method, so that is the first method. Second method is, you see the upper inflection point. If upper inflection point is telling you it is around 18, you just crank it up to 18 and slowly start bringing down the PEEP to determine which is the best, because you want PEEP somewhere to be here where it is optimally opening up all the alveoli. So incrementally start bringing down the PEEP, and you bring down the PEEP until the saturation drops to more than 2%. You see the oxygen saturation, slowly reduce the PEEP from 18 to say 17 to 16. Suddenly if you see saturation coming from 96 to 94, then you know that is the optimal PEEP. Or you look at the static compliance, and if the compliance is say 20, then you see if it comes down at the point at which it comes down, you call it as an optimal PEEP. So this is the way, easiest bedside way that we titrate the PEEP. So what do we understand by high PEEP? So as I showed you in the figure, if you give only tidal volume, basically this is a normal alveoli which anyway opens and closes because of the tidal volume. So these two are collapsed alveoli, they don't open up. But if you give tidal volume with PEEP, this collapsed alveoli also opens up like this. So that is why this we call it as open lung. Open lung ventilation is simply you're opening up the collapsed alveoli. So benefit, what is the benefit of high PEEP? Because you're opening up this alveoli, you are getting more alveoli to participate in gas exchange. So you are bound to improve your oxygenation. But whether high PEEP, we saw low tidal volume, at least 3-4 studies we saw, big meta-analysis which showed that there is a good mortality benefit. But has high PEEP shown good mortality benefit? I think that remains a question to be answered. That remains little uncertain. So this was a study which came from Canada. As you see, it's a big study, meta-analysis of 2,299 patients. So they had a high PEEP group, low PEEP group. Look at the ICU mortality, significantly less in high PEEP group as compared to the low PEEP. That was statistically significant. Hospital mortality, there was no huge difference. Oxygenation significantly improved in high PEEP. Ventilatory free days improved in high PEEP. And in high PEEP group, there was no need for rescue measures. So this study really showed that high PEEP is beneficial. And what it was also found is the benefit they found was in severe ARDS. Severe ARDS or moderate to severe, where I said PaO2, FiO2 less than 200. But if you have a mild ARDS, high PEEP can be dangerous. That's what this study showed. So your PEEP and optimization of the PEEP or the high PEEP, you should reserve it to moderate to severe ARDS where PaO2, FiO2 is less than 200. Because less than 100 is severe ARDS. So keep that in mind. If it's a mild ARDS, don't give very high PEEP. Okay. So this was another study which came from an Argentinian group. Again, a big study of systematic review, 2,565 patients comparing high PEEP and low PEEP. Hospital mortality, there was no difference, but oxygenation improved in high PEEP, and the mean difference of improvement was 41 millimeter mercury of oxygen. Ventilatory free days, there was no difference, but what significantly they found, the ICU mortality. Even the Canadian study showed ICU mortality was significantly less. Even this Argentinian study showing ICU mortality significantly less. And more so, ICU mortality was less in patients with moderate to severe ARDS where PaO2, FiO2 was less than 200. And that was statistically significant. You can see the confidence interval to be very significant here. So there are two studies, big meta-analysis, which have shown that high PEEP has mortality benefit in ICU, improves the oxygenation. So the conclusions they made were high PEEP in moderate to severe ARDS improves oxygenation and improves mortality, but mild ARDS maybe you avoid giving high PEEP. So moderate to severe is where you can consider high PEEP. But what the clinical outcomes, why is it different? Why clinical outcomes are different? Because of the heterogeneity of the lungs. So here the concept of driving pressure comes, because heterogeneity of the lung means there are certain areas of the lung which are recruitable. You saw that figure with collapsed alveoli. Some of them open up. Some of them, even you provide high PEEP, they don't open up. That we call as non-recruitable alveoli. So if you have recruitable alveoli, high PEEP will be benefit. But if you have a lung, the nature of the disease is such that your alveoli is unable to open, then high PEEP can be detrimental, because you'll keep on increasing the PEEP, but alveoli are not opening, but the other alveoli will open up, rupture, and it will cause barotrauma. So that becomes dangerous. So as I said, high PEEP in recruitable can be beneficial, but if in a non-recruitable, it can cause stress trauma or it can cause barotrauma. So that's something you need to very clearly understand. So what are the harms of giving high PEEP? Because you put high PEEP, so if it is increase in the plateau pressure with high PEEP can cause, as I said, ventilator-associated lung injury or barotrauma. But most importantly, what we see on the bedside is you keep on increasing the PEEP, your venous return to the heart comes down and you can have hemodynamic compromise. Your blood pressure can start coming down. So this was the study, they compared whether barotrauma really happens with high PEEP. So this came from US group. In 549 patients, they looked at it and they felt even high PEEP, the barotrauma is overemphasized, it really doesn't cause. So you can sort of tend to adopt high PEEP is what they've shown. So, and the PEEP, you can, so that the one way of applying the PEEP is to look at the lower inflection point. The other way to apply is just follow this diagram. So if you do not want to apply that science on the bedside, just you fix your FiO2 based on the PaO2, and you have this ready-made table for around FiO2 of 90%, you have a PEEP of 22, for 80% you have a PEEP of 22, for 50 to 80% you have a PEEP. So this is a ready-made table which you can apply and customize or titrate it to the PaO2 and the FiO2. So this is a simplistic one. If you really do not want to apply the lower inflection point and looking at the curves, I think this is something you can adopt and then titrate it to your PaO2 and FiO2. Okay, so I think the most recent concept that we have learned in intensive care about plateau pressure and PEEP is combining both. So what you learned now, low tidal volume is the way to go, high PEEP is the way to go, in moderate to severe ARDS. But what we have newly understand, just around 2 to 3 years back, this landmark article came in NEJM. We have understood a concept, something called driving pressure. So driving pressure is combining your plateau pressure and PEEP. So driving pressure is nothing but the tidal volume titrated to the compliance of the respiratory system. On the bedside, simply it is done by you calculate plateau pressure, which is determined on your by tidal volume. You lower the tidal volume to lower your plateau pressure minus PEEP. So you have to keep the driving pressure as low as possible. So 15 is the ballpark. So try to get the driving pressure by optimizing either low tidal volume or increasing the PEEP. So this is what we have understood. So the rationale for protective lung ventilation, which I am again repeating, is to reduce the VALI, ventilatory associated lung injury, improve the oxygen and improve the clinical outcome. We do this, again I am repeating what I have already said, by adopting low tidal volume, low plateau pressure, high PEEP. If you remember at the end of my lecture these three things, I think it's good enough, because as I said, this science is complex for non-core ICU members. But if you just remember these three, low tidal volume, high PEEP and P-plat and driving pressure, I think I've done my justice in making at least remember this. Please use low tidal volume and optimize the PEEP. That's all you have to remember. And what do we understand by driving pressure? Because right now we have said the tidal volume has to be titrated to the predicted body weight. So what that means is, I've shown you that other figure before where your alveoli are very different in different areas. So there is a hugely heterogeneous. So if you have a pneumonia and ARDS like this, so this whole part of the lung has reduced compliance there. But in the area of the lung with reduced compliance, you are giving the same tidal volume which you are giving to this normal lungs. And that leads to problems. That's what we have realized. So what that problem it causes is it produces tremendous stress to this area of lung affected and can lead to volutrauma or barotrauma. Our whole aim is to restrict the tidal volume to the functional size of the lung. So our whole aim is to give tidal volume which is enough for all these normal areas and ignore this. That is what we call as functional size. And this we have understood by adopting this driving pressure, which is P-plat minus PEEP. Okay, so that simply understand driving pressure as the functional size of the lung and titrating tidal volume to the functional sizing of the lung. So this is a landmark article. We have also, as intensivists, core intensivists, we have learned the concept of driving pressure only in 2015 from this article, which came in NEJM by Amato. It was a retrospective analysis. They took all the 9 trials. What they found is driving pressure had a direct correlation to the mortality benefit, which means you keep the driving pressure low, patients survive better. If you keep driving pressure high, patients can die. I think that is what we have understood. And the second thing they looked at is trying to understand the combinations of plateau pressure, PEEP and driving pressure. Okay, I'll just take you through that. So they have looked at driving pressure, if it is titrated to tidal volume and compliance, had a better predictor of mortality. And the first analysis they did, they saw that driving pressure benefits was seen in 75% of the tidal volume trials, and driving pressure benefits was found in 45% of the PEEP trials, which means to say, if they have looked at wherever the driving pressure was less, I think they saw a huge survival benefit in all the previous trials. 9 trials they looked at previously and they found that benefit. So I think this graph, if you understand, I think you have made justice to your presence here. This is a very important graph. So as I said, P-plat we want less than 30. So if P-plat is increasing, okay, which means you have to reduce the tidal volume, but you are not tweaking the PEEP. So you are not optimizing your open lung ventilation. What happens? P-plat minus PEEP is the driving pressure. So your delta pressure keeps rising. I'll just take 10 more minutes. So delta pressure keeps rising, which means your mortality increases. So this is very important thing for you to understand. If P-plat or plateau pressure is increasing, okay, so which is bad, then you have to reduce the tidal volume. Then you are continuing to increase the PEEP to keep, and delta pressure is the same. So then mortality is either not increasing or not reducing. But what we really want is this. If P-plat is the same, so you are reducing the tidal volume, and PEEP you are continuing to optimize, then which means P-plat minus PEEP, delta pressure is falling, then your mortality reduces. So any ARDS patient, we want this behavior to happen. But this is not in my hands, because if compliance of patient is so poor that I am unable to get down the P-plat, although I increase the PEEP, your driving pressure remains the same. So these two may not be beneficial. But if I have a patient, basically your whole driving pressure is to help understand which patients will survive, which patients will not survive, or which patients will remain as a plateau without improving or getting better. So the conclusions they made was driving pressure stratifies the risk of patients in ARDS, and the concept of protective lung ventilation is moved to functional size of the lungs. So trying to ascertain what is the functional size and delivering the tidal volume to that functional size is what we have understood. And most important for all the listeners here is, if driving pressure is kept less than, as low as possible, less than 15, then you know that patients have to survive. There's no reason why they should die. And just 2-3 slides on prone ventilation, because we prone the patient. So we prone means we put the patient head down and ventilate them. So that came from this landmark study. So we prone the patients in severe ARDS within 16 hours. As soon as we realize that patients are very sick, we prone them for 16 hours. And the indication for proning is, if you have a severe ARDS patients where your PaO2 by FiO2 is less than 150 and your oxygen delivery is more than 60% with PEEP of more than 5, with your low tidal volume, still you are unable to achieve good saturation. I think these are the group of patients where we tend to prone. And there are certain contraindications for proning. So when we have a patients who have to be proned, so anyone with a head injury, we cannot prone. Someone who has hematemesis, we cannot prone. Someone who has a cervical spine issues, we cannot prone. Someone who's undergone chest surgery or abdominal surgery, we cannot prone. Or someone who's having cardiac arrhythmias or dysrhythmias or hemodynamic instability, they are very hypotensive. So these are some of the things that you should keep in mind. These are the patients which I cannot prone. Suppose a neurosurgical patients or traumatic brain injury patients develop ARDS, I cannot prone. Or if patients who is very hypotensive, I cannot prone. Someone who has undergone chest surgery or abdominal surgery, I cannot prone. So, and you have logistic, you need to have good manpower to prone, because you need to have adequate gear, you need to have all those cushions so that the pressure points are spared and they don't develop any problem. And following proning is not free of problems, so they can have a lot of problems. They can have a lot of secretions coming out. You can have a lot of edema, conjunctival edema, and the endotracheal tube can migrate when you prone, and some of the lines can come out when you are proning. So you have to take a lot of extraordinary precautions, and you need to have at least 4 to 6 nurses when you're proning, and even the Ryle's tube can sort of migrate. So you can have a lot of gadgets that are connected to the patients coming out. So you need to train yourself as to how we prone them safely. And proning also can cause some oxygenation issues. And when you prone, patients will need to be put on neuromuscular blockers so that they are not moving, because when they are moving, then it can create a lot of problem. And they should not have any dysrhythmias. If they have some arrhythmias, then you cannot shock the patient. So these are some of the problems that you may have with proning, and you need to be aware of that. But proning is the way to go. So all our severe ARDS, we prone them because it has shown to have significant survival benefit. So recruitment measures, I'll just couple of slides. So recruitment measures. So we talk about low tidal volume, optimal PEEP, driving pressure. All this is still not helping. Then we have to talk about recruitment measures. So how do we do recruitment? So we increase the PEEP to very high levels, 35 to 40 centimeters of water for around 30 to 40 seconds. So what it has shown is it transiently improves oxygenation, but the studies have shown it has no effect on mortality, length of stay or barotrauma, which means you successfully improve the oxygenation, but you may not help the patient to survive. So it is a very sort of a contingency or a transient measure to improve the oxygenation. And we do not have consensus what is the ideal amount of PEEP. So we have a ballpark figure where we increase the PEEP up to 35 to 40, but whether that's good enough or it should be more than that, we do not know. We do not know the duration, although we said around 40 seconds, 30 to 40, we do not know how much duration will help, and we do not know the frequency. And recruitment measures, as I said, if you increase the PEEP, you have a huge problem with hemodynamic compromise. So in recruitment measures, you are increasing the PEEP to extraordinary levels, which can cause severe adverse effects like fall in blood pressure or fall in saturation. And there is something called PSI breaths, which means cyclical PEEP we apply for 3 to 4 minutes up to 45 centimeters. So it is similar to the previous methodology I mentioned. So what happens with recruitment measures? So as you see, so this is the pressure volume curve. So you keep on increasing the PEEP, and you see these are the collapsed lung, how they open up. So transiently it will improve, but then once you get the PEEP back to the baseline, again they tend to collapse. That's why it has not shown to have mortality benefit, although transiently it improves the oxygenation. So when you have a patient typically in the supine position, you see these are the collapsed alveoli. So when you do a recruitment maneuver, you sort of recruit this collapsed alveoli, but prolonged recruitment can cause over distension of these non-dependent areas, which can again lead to barotrauma. So there is a risk of barotrauma when you're doing recruitment maneuver because of this. So how do? We need two people to be present at the bedside. You have to adequately sedate the patient. Patient has to be connected to a monitor, and then you have to look at the airway pressures and static compliance on the ventilator, and keep a close. Patient should be connected to a fluid bolus. Vasopressors has to be started because your blood pressure can come down and it can lead to cardiac arrest. So you have to take all precautions to manage your hypotension episode that happens with recruitment by having fluid bolus and vasopressors in hand. And the success of recruitment is indicated by improvement in the oxygenation and improvement in the ventilation and improvement in the compliance. So these are the three things that we see whether your recruitment measure has really helped the patient. So whether there's any difference between the modes, I won't get into the depth of this. So all the studies have been done with volume cycled ventilation, most studies, and the familiarity with volume cycled is more. So volume cycled is where you set the volumes, pressure becomes a dependent variable. In pressure control, you set the pressure, volume becomes a dependent variable. So airway pressure release and high frequency are not routinely recommended in ARDS. So refractory hypoxemia, so just last couple of slides. Refractory hypoxemia, so suppose you have done low tidal volume, you have done optimal PEEP, you have done open lung ventilation, you have got the driving pressure less than 15, used recruitment, still patient is hypoxemic. So then you can tweak with IE ratio because you increase the inspiratory phase. When you increase the inspiratory ratio, you reduce the flow rate. So it will increase the mean airway pressure. That will improve the oxygen. But the need for sedation will be more if you increase the IE ratio or if you increase the inspiratory ratio. And how does that increase? Because if you have increased the inspiratory time, what happens is it will reduce the expiratory time. So once reduce the expiratory time produces auto PEEP. Because you have less expiration, more carbon dioxide accumulates. Our concept is that it will open up the alveoli. So that is how tweaking the IE ratio will improve oxygenation. So you increase the inspiratory, expiratory automatically comes down. When expiratory comes down, your carbon dioxide is retaining, and that will contribute to the auto PEEP, and that is known to increase the oxygenation. So titrating PEEP, there is another method with esophageal pressure. We call it as a transpulmonary pressure. Transpulmonary pressure is just a difference between airway pressure and pleural pressure, and we take that as a surrogate of optimization of the PEEP. And the airway pressure is nothing but the PEEP. So it is just the difference between tidal volume delivered and tidal volume received. So transpulmonary pressure for recruitment has to be kept less than 25. If it is because transpulmonary pressure is the total airway pressure, and that total airway pressure minus pleural pressure, and if it's very high, it can lead to barotrauma. Okay. So these are something, I think I'll just take you through this figure. It's extremely important. So you have an alveoli like this. So just to give you or make you understand the concept of transpulmonary pressure. So you have an expiratory phase, you put a PEEP of 5 in non-dependent lungs, which means a nice lung which is opened up. Airway pressure is 5. So airway pressure is PEEP. Okay, and the pleural pressure is always negative in spontaneously breathing. Your transpulmonary pressure is 5 minus, I told transpulmonary pressure is airway pressure minus pleural pressure, which becomes 6. So this is the collapsed alveoli. So you put a transpulmonary pressure is 5 and the pleural pressure is 2, it becomes 7. So inspiration, in inspiration we put a pressure support. So your transpulmonary pressure becomes 15 and your transpulmonary pressure in dependent part becomes 18. And this 15 here leads to volutrauma. So we do not want this. So this really does not help in getting our patients better. So now you increase the PEEP because our whole concept is we want to optimize the PEEP. Increase the PEEP. So here you get a transpulmonary pressure of 11 and here you get a transpulmonary pressure of 12. That is still not opened up the alveoli in expiration. Then you put a pressure support. It is opened up the alveoli, but it is still not adequate. Because the alveoli is not fully open, it leads to atelectotrauma. Even this is the situation we do not want in our ARDS patient. Then we go to the third scenario, increase the PEEP further to 14. So your transpulmonary pressure becomes 16 and 18, which is good in expiration. But inspiratory phase, both are opened up overtly because you put a pressure support of 8. Your transpulmonary pressure is more than 20, which can lead to barotrauma. So it leads to barotrauma. So this also is not the situation we want because expiration is okay, but inspiration you are causing barotrauma. What we ideally want is this. So you put a PEEP of 14, your transpulmonary pressure is adequate to open up the alveoli, but in inspiration, you reduce the pressure support to 3 because that will help you in reducing the transpulmonary pressure to just around 22, which is the ideal thing. So this is what we want. So summary and recommendation. So that's the, I think that concept, I recorded this, I'll put it on the website, watch that again. That is the core essence of the whole ARDS ventilation. So summary of mechanical ventilation. So invasive mechanical ventilation is preferred in all moderate to severe ARDS, grade 2C recommendation. Volume controlled ventilation or pressure controlled ventilation, any of them you could use it. But pressure controlled seems to be more extensively studied of late. And low tidal volume, low tidal volume, low tidal volume, low tidal volume is the way to go to ARDS. That gets grade 1B, strong recommendation. And plateau pressure has to be less than 30 centimeters. That gets grade 2 recommendation. If PaO2 by FiO2 is less than 200, moderate to severe ARDS, use high PEEP, grade 2B recommendation. And preferred approach is not established. Like what is high PEEP? I think that we have got to understand with your driving pressure. If PaO2 by FiO2 is 200 to 300, then high PEEP may not be beneficial. So if it's a mild ARDS, don't give high PEEP. And open lung ventilation with high PEEP with recruitment maneuver may be useful in moderate to severe ARDS, but routine use still needs to be investigated. So thank you very much. I end this with this talk. Comfort zone is a beautiful place, but nothing ever grows there. So if you are in a comfort zone of not understanding ARDS ventilation, then we may be doing more harm than benefit. So unless you know the core science of ARDS, I think it is good to be in a place, for the patient to be in a place where the science of ARDS is well understood, the science of ventilation is understood, because by just putting patient on ventilator and not adopting to this core science can kill the patient with ARDS. So you can visit my website www.Dr.Pradeep Rangappa. So there are more than 100 lectures uploaded. It's a free, absolutely free. You can watch all the lectures. This lecture is recorded. You can rewatch it. And although I rushed through that last slides, please go through them because they form the core essence of ARDS now and the driving pressure. So thank you very much. And I thank Columbia Asia for giving me an opportunity. I exceeded my talk because my another colleague may not be coming. So I think I have taken his bit of time. Thank you, Anant, and thank you, Firoz, for having me here.